So I almost begin every engagement or speaking engagement, step out of range of the speakers, so I don't cause any feedback. With an encouragement for you guys to ask questions and have a conversation. Like, this is a small and intimate group, and have a much more interesting conversation than us sort of jawing at you from the front. But I'm not going to presume you actually know anything about the Design Institute for a moment, and give you a little bit of grounding about who we are, how we came to be, why we're hanging out here with you guys, and some of the things that we've actually been doing over the course of the last year. So we've just crossed our 1-year anniversary, which is remarkable because it's felt like 6 weeks maybe. And we are eminently busy with working on a really remarkable opportunity here in Austin. So I'll talk a little bit about that. So I'll start with the foundation piece, which is the Design Institute for Health is a joint collaboration between the Dell Medical School and the College of Fine Arts. And there's a reason for that. The Dell Medical School, as you know, is at the heart of a broader effort in Austin to sort of remake essentially what a modern health system can be. And it would not be, I think, an exaggeration to describe the opportunity in Austin as a one of its kind and maybe once in a lifetime, essentially to build a model for how the rest of the US healthcare system will work, and probably globally as well. We've had a lot of interest in conversations with people. And so the dean of the medical school is a friend of mine, who was both a client and a friend of mine when I worked previously at IDEO in California. And when he came out here to become the dean of the medical school, he said, fundamentally, we're trying to take a creative approach to building a new model for healthcare. And I've got teaching faculty, and I've got clinical faculty, I've got a big research university and all these sort of resources, but I don't actually have any designers. I don't have anybody with sort of a creative, artistic, innovative background helping us think about how we could break the mold and think differently about all of this. Would you be interested in coming and lending your perspective to that? So that was obviously very enticing. We fell in love with the opportunity. I stole Beto from IDEO and actually a couple others as well. More than a few of our staff were folks that we collaborated with at IDEO. And intentionally create an institute that sits between the College of Fine Arts and Dell Medical School, because the College of Fine Arts is where design is housed at UT. And it's a growing discipline out in the marketplace for certain, right? The ability for people to think creatively around problems and solve for issues that haven't yet been addressed is really not a function of traditional science or analytics or business. It is a creative endeavor, and the fact that it's housed in the College of Fine Arts is a fantastic representation of that intent. And so we've been spending our time here. That's what was a coffee shop is now our design studio, and we still occasionally have students walk in and try to order a latte and realize they're in the wrong place. But it's been great to be here because it separates us from the sort of monolith that is traditionally medical, healthcare, establishment, right? And how it allows us the freedom to think more broadly with creative partners and have a neutral space on campus that engenders that kind of collaboration. So that's the Design Institute. We really have initially three major aims. One is to help redesign the system. So we're working with a lot of regional partners, hospitals and caregivers and financing entities, civic and community organizations, really trying to remake the model here and figure out how we can operate differently. And so we're designing all sorts of things, from spaces to patient experiences to provider experiences to technology infrastructure, business incentives, you name it, we have a hand in really a privilege, actually. And so remaking the system, redesigning the system as a model for how others can work is one major focus of our work. A second one, which we've begun working in earnest, is actually developing Austin as a center for health entrepreneurship. We don't actually believe you can build a new system on existing capabilities, so you have to bring new capabilities in the system. And I think that's some version of the definition of insanity, right? Is trying to do something different with the same assets. And so we believe we actually have to bring new entrepreneurs to Austin. And we have a unique opportunity to do that because we have a system that's going to operate like something in 5 to 10 years in the future. And if you're an entrepreneur in healthcare, typically you're stuck trying to get access to a health system if you're trying to have big impact. And if you are lucky enough to get access to a system, most of those systems are only looking incrementally a year or two out. And so their courage to be creative, their courage to try new things, to express their care and their offers in different ways is really kind of limited. Here in Austin, we don't have any of that legacy. We're bound to, so we can actually think really creatively about what the system should look like, and we can, we essentially have a test bed where people who are trying to try new things for a model that's going to be 5 to 10 years out can participate. And that should be of mutual benefit. We need those new entrepreneurial capabilities to build a new system. They need us to market test, and so it should be a symbiotic, sort of beneficial, mutually beneficial relationship. So that's sort of the second major aim. And then the third one is a little bit more meta, and that is we're just trying to make people understand the value of design as a whole. Right? So we're a resource to the region. We work not just with the medical school or with UT. We work with Seton and the Central Health and the Community Care Collaborative. We're working with community members. We're working with a whole bunch of different groups, trying to figure out how to help evince the value of design in really tangible ways. Right? Like you can stand up here and talk and hand wave a lot about design and its philosophy, but ultimately design, as in any artistic endeavor, results in really tangible things that have an emotional impact on people. And we want to create those things as fast as we can so that people begin to understand what design can actually evidence in real world impact. So, so those are our major aims, and those will certainly revise and evolve over time. But that's the work that we've been primarily focused on for the first year. I've got a lot of tangible examples of work that we've been doing, and I'd love to share those because I think those will be a lot of fun to talk about. But I'm going to pause there for a moment and see if Beto has anything to add.
Only as much that recognizing that design thinking is a celebrity in the room, and that what we're trying to also do is bring about an awareness and a value of design doing, which goes hand in hand with what we're doing with the health ecosystem here. It's not just thinking about new ways and new approaches. It's actually getting your hands dirty and building things that we can imagine are possible. That's the conduit that helps us create impact. It's design doing, not just design thinking. Knowing that design thinking is a celebrity in the room, it's something that is increasingly valuable to employers, to the marketplace, to the people wanting to create transformative changes in education, in healthcare, in government. But it's more than that. We're trying to make sure that it's more than that.
Yeah, I'll reinforce that for a moment. I think when Beto first said that maybe a year ago when we were first arriving on campus, I kind of scratched my head and says, like, do people really get that? And over the course of the year, I've completely embraced it. And the reason is design methodologies, which has now been, called human-centered design or design thinking, has become a bit of a celebrity, right? It's like, oh, this new age, nouveau way of thinking, right? And I think it actually does design a real disservice, because design is about actually creating real things that people interact with, right? And so the doing part has gotten lost in the thinking bit, right? So the marketing, the PR around design thinking has been strong, and we've all sort of benefited from that. But I think the pendulum has swung a little bit too far, and people think of it, oh, it's just a new way to have conversations about things and think, high thoughts about it. And our response is yes, but that's only in service to actually doing something, executing, creating things that people actually interact with. So it's an important thing that I think we will continue to push on. Yeah. So I'm going to pause for a second. So in the spirit of having a conversation, before we start describing all the tangible things that we've been doing, I'd love to see sort of questions or comments or interest about what you want us to talk about, or questions that we've.
What do you want us to talk about?
Yeah. We are not the sole progenitor of new ideas and new ways to do things. Without a doubt, that's not true. There are really remarkable people joining the medical school who all in their own right have established careers of significant note in places with great prestige, right? And they're all coming to Austin and taking huge risks career-wise because they have an entrepreneurial spirit and they believe they have an opportunity to create something new here that doesn't exist anywhere else. And that's, I think, a really consistent thread among all of the personalities that have come. So I'll return to an early part of your question. So we are enablers. We are enablers. Yes, we have a lot of perspective, a lot of experience in designing things in health and healthcare over the years, in building things for complex systems and evincing change across broad, complex systems. And so we have some ideas for things that should evince, but we are also enablers. No small part of our responsibility is actually helping maybe the most jaded, ossified industry in the world, healthcare, think in more creative ways and approximate some of the skills of creative artists and designers, right? And so that's no small challenge, obviously. And part of the role of design student is actually to demonstrate first. So we could actually push and pontificate and teach and all that stuff, but there's no better way to invoke change than to actually show what happens when you actually apply a creative approach. And we're not applying that just to, a medical school by definition is there for the education and training of future physicians and healthcare leaders. That in itself needs a big rethink, without a doubt. And so we're going to contribute to that in teaching those new students things like leadership and innovation and creative problem solving and systemic modeling and things like that. But it would be entirely insufficient to just train physicians, because if we did that without actually thinking about the system they were going to operate in, we would essentially train individuals to be unemployable, right? They would leave this medical school looking like no other doctor the system had ever seen, and they would just, like a bad virus, the system would reject them, right? Sorry, appropriate analogy, but a little bit nerdy. So it's insufficient for us just to rethink the education of the physicians. We actually have to design a system in which they can operate. And the system needs to change. Like, there's no small motivation, right, to change that. It's bankrupting our economies globally, our healthcare, despite massive advances in technology and all that kind of stuff, really hasn't improved tremendously. We're going to raise a generation of children who are going to be the first ones that are less healthy than we are. Like, there's massive issues. There's real reasons for the system to change. And one component of that is training individuals who work in it differently, but a major component of that is actually just redesigning the system itself. And so the medical school is part of a coalition, that includes Seton, the hospital, and Central Health, which is the funding mechanism that draws property taxes from the residents of Travis County and pays for a lot of the healthcare in town, to actually rebuild a system or build a system afresh that actually operates very differently. So we are agents of change, but we are not the only ones in the room.
You evoked a concept or a metaphor of an incubator. We're not an incubator, but we do allow ideas to persist longer than we normally allow. Crazy ideas are part of change, and as we work with a bunch of the leadership within the medical school who have crazy ideas, awesome crazy ideas, we need to give them not just tangibility, but space and time to mature so that they aren't just immediately dismissed on paper, on surface, that they have a chance to evolve into the intention that was behind those ideas. And so we do provide a fair amount of buffer for allowing ideas to actually be a better currency and kind of within the medical school, but also within our stakeholders, within the community of stakeholders who are working together to transform health here in Central Texas.
I'll build on that analogy a little bit. It's really endearing to be part of College of Fine Arts for reasons that are sometimes hard to express, but as an engineer by training, I was trained in really logical, rational ways, but I'm also a musician on the side, right? My wife says, you do emote occasionally, right? And so that's nice. and so that balance of left-right brain is actually really, really important. And I'll give you the analogy. If Pablo Picasso had proposed what he was going to paint to a panel of authorities, right, he would have never gotten to where he was, right? And that's the state of healthcare, right? We have a bunch of people with authority and rules and regulations and boundary conditions that they tell you all the time that things can't get done. And so part of our responsibility is actually to create a landing pad, some room for people who are a little bit crazy, actually to think new and crazy thoughts, and then actually help them distill that into something that actually events really miraculous change on the system. And so I think we really embrace that role, and being part of fine arts actually gives us license to do that, which is nice. There's a project we coded FDR when we first started here for Franklin Delano Roosevelt, and the name of the project ended up being called the New Deal. And the reason we named it that way was because we wanted to reorient the traditional healthcare system to what actually people want. Like, if you ask a doctor, my wife's a doctor, you ask a nurse, my friends are nurses, right? You ask hospital administrators, my collaborators are those, right? What the system needs, they'll do it from their point of view. And they forget for a moment that they're actually people too, and that when they go to the hospital, they go to a clinic, or their child goes to, that they have an experience that is really, really generally miserable, right? And so So we spent quite a bit of time in last summer actually spending time interviewing people representative of Austin, and I've shared this publicly before too, but a bus driver on Cap Metro who, in addition to her own health issues from having to sit on a bus and drive it for 8 hours a day, is also a sensor for the community. She knows when Bob, who gets on the bus every morning, is doing well, not doing well. What does it mean to understand the health of a community through people in the community? We talked to a blues musician who's a 68-year-old blues musician who's homeless. We talked to an ex-convict who was trying to reintegrate with society and to rediscover his health in the midst of that. We also talked to people who worked for tech companies in Austin, a real estate entrepreneur who's been really successful in Westlake. We really tried to get a broad swath of Austin, but the goal of that was actually to re-characterize health and health care from the point of view of the person being served, because the system mostly ignores that, right? And so that has been a foundation for so much of the work that we've done, because it's really helped challenge the norms and the associations that people have about what is true about healthcare and what needs to be done. So
it's a core design skill set, which is design research.
Yep.
Qualitative design research built on open-ended questions and conversations with what we're calling extreme stakeholders in the community who represent very drastically different needs and conditions. Part of applying design thinking is understanding the tools that we wield. Part of those tools are how do we connect with people to help uncover the things that motivate them. The design research is one of those tools. This project was exemplary of design research. It's a tool that we have that is able to distill those motivations, those needs, those unmet needs into a narrative that we can play back at an anecdotal storytelling level. Stories are really the currency that help us communicate broadly across different disciplines. If I were to teach you or tell you about what's happening from my particular expertise and domain, you might not get it, but you do get stories. And so part of the designer's tool set is storytelling, and how do we elevate things to a narrative that we get because we are empathic, because we understand needs, because we can sympathize with that situation or that condition. That's a core design skill set.
Yeah, it's an age-old mechanism for connecting people to other people, right? Our oral history is how we pass down our learnings and our intelligence and our wisdom over the years and over generations. And again, the health system has managed to push that out of their operations. They work on inscrutable metrics that and commercial value that don't really address the core of human needs. So that's really critical.
I'll refrain with what are the tools that we're using so that we anchor it into how you can imagine this being connected to the design division within the College of Fine Arts.
Yep. So then there's been a particular focus driven by the fact that a lot of concrete is being poured just a couple blocks away from here for the new medical center. So there's a hospital, education administration building, a research building, outpatient medical center, all of those things are being built. Because the concrete's gone up, something has to go inside it. And so we've been spending a fair amount of time actually working on the more clinical side of the enterprise, and that's driven primarily by the construction. But we haven't shied away from that opportunity. So we want to fundamentally remake the experience. So if any of you ever had, a lot of you look young, so I'm guessing you're still invincible and haven't had a lot of experience with the healthcare system, and that's good, because hopefully by the time you do, it'll have been rethought. So traditionally, we want to rethink that from an experience standpoint, not from a what is the outcome of the system, but what are the kind of emotional and human experiences you're having as you traverse that system, because mostly it's unremarkable and usually quite poor. So we started with the humans in the system, primarily the patients first, right? And what kind of experience do you want to have as you go through that? And the benefit of having worked at a company like IDEO for more than a decade is we had colleagues who worked in all other kinds of industries, right? Hospitality and transportation and education, all those sorts of things. And so we were granted the perspective of industries that were way ahead of healthcare in terms of experience, right? You walk into an Apple store, that is a designed experience. They did that explicitly to create a mechanism to take more money out of your wallet, one, but also to create an incredible brand allegiance, right? Nobody, like, I love the question in healthcare, which is like, what's the best brand in healthcare? And you're like, there's none, right? There's none. Like, you can't think of a healthcare brand where you're like, oh, I love that brand in the way that people love Apple or love their GoPro or love whatever, right? Love Mini, like, or their Fiat or whatever. It doesn't matter. It just doesn't exist in healthcare. And so we need to return some of that opportunity to healthcare. And so we've been rethinking the patient experience. You know, easy shortcuts are we eliminated the waiting room, right? And it blew the architects' minds. They're like, what do you mean you're eliminating the waiting room? I have specifications for how we design waiting rooms and how big they are relative to how many other patients. They're like, that's specified. We have to have a waiting room. We're like, no, you don't. Like, why do you have to have a waiting room? Well, where are people going to sit when they're too early for their appointment? And you're like, you're asking the wrong question, right? Why are they too early for an appointment? Are they too early because the physicians want to back them all up so that they can always be busy? Probably, right? Are they too early because they're concerned about missing their appointment because they get dinged when they're late? Maybe. Are they waiting because they have nothing better to do? Probably not. Everyone has better things to do than sit and stare at the fish tank, right? So we really are challenging that notion, and not just eliminating the waiting room, but how do you create more ownership for the patient as they move through the experience, right? When you go check into a hotel, right, you're not visiting a room that belongs to somebody else. As soon as they give you that key, that room is yours for the duration of your stay. But that's not the case in healthcare, right? Like, anybody can walk in while you're half denuded, like changing from your clothes into that gown, which moons everybody. And so really, how do you return a sense of normalcy, of humanity, of control back to the patient and to their family? Oftentimes, family come along to support their loved ones who are having a procedure or surgery, and then they're told to sit in the waiting room away from their loved one, or go away for 8 hours and we'll page you at best, or call you when you should come back. Like, what's the point in that? So could we grant them a place to stay too? That's a family room that's for both of them. And then the other piece is then recognizing that there are other humans in the system too who happen to be the people providing care, the doctors, the nurses, the staff, and they've been pushed into a system that's really unpleasant to work in, right? Most doctors now will tell you, this is not exactly what I signed up for, but I'm now manipulated. I'm just a cog in the works. So we've been rethinking those as well. And you can talk about some of the specific service blueprints and technology and all that.
Yeah, just like product design, which should be way more familiar for you guys, isn't just the domain of an industrial designer. You need engineers, you need manufacturers to really think through the development of a product and deliver it into the marketplace. Service design is not just the domain of user experience designers. You need business designers to understand kind of the operational model of what you're trying to deliver and how you do that. You need technology systems on the back end to understand how that information that you're capturing for that customer is being carried from one moment of an interaction to another moment, ultimately creating some benefit. Service design is something that we're employing a great deal when we're rethinking how we bring together a collection of providers who has historically been in many different places and all asynchronously presented to the patients. We're co-locating them now. We're creating team-based practices where we bring together a whole bunch of providers in one room, actually one big building, to render care because we've redesigned and rethought the business model and the operational model for value-based care, which is this idea of creating measurable outcomes. When you employ something like service design, you need to bring in so many other disciplines, and it really becomes this multidisciplinary effort to create really amazing services. If you look at Starbucks or if you look at Disney, it's not just their designers who came up with that. They work together with a whole bunch of people to imagine what could be possible. What I take away with that, and what I hope you guys take away, is that we're not trying to make your healthcare experience like Starbucks. There are aspects of what Starbucks does that are immensely applicable to what we're doing. But we're not trying to commodify it. It would be incongruent to think that we're using service design to just create an Apple store within healthcare. No, we're trying to learn from why the Apple store, why Starbucks, why Disney succeeds so brilliantly in getting you to feel delight, to feel like you're connected, to feel like problems have been solved for you, and bring those notions and those capabilities, not the solutions, into healthcare. When you do that, you have to still have designers, graphic designers, industrial designers, user experience designers, to really blend what that means for health. And so it's this new space that we're working in, and I think that that's one of the spaces that's most interesting to someone who's thinking about design as a career or is in design right now, because it's a transformative thing that's happening in every category, in every marketplace today.
Yeah, so in addition to challenging a lot of the norms for how the health system traditionally works, maybe the biggest one is convincing them that nothing is set in stone, which is anathema to the way the health system works, right? They describe a protocol and you follow that to the ends of the earth, even if you know halfway through it's not going to do any good. And there's a lot of reasons for that, which I won't go into, not the least of which is how they get paid. But, and so a notion that, a phrase we use consistently is this notion of a learning lab, that we're creating an environment that is honest about the fact that health and the health of individuals and health society and its priorities will continue to change, and that the delivery of that health and the mechanisms that are delivering that should actually continue to evolve along with it. And then the last thing I'll talk about before we open up to questions, I see Doug has run away, so we can't ask him any more questions. So I'll tell you about 4 entities. One is the medical school. We have these big buildings where medical care is delivered, right? Traditionally beige, sort of 4 walls kind of notions that are really unenticing, right? People don't choose to go to hospitals or clinics unless they're ill, right? They don't choose to go there because there's something interesting to see there. So that's sort of the history and legacy that we're saddled with. And then we met the CEO of the Thinkery, which is the Children's Museum here in Austin, right? And he's a fantastic guy, and he's like, learning should be happening everywhere, not just in a traditional museum. How do we take the notion of learning out into the environment? How could we turn the medical campus into a place that's learning in a really creative way? We're like, it's a really interesting provocation. Don't act on that yet. And then we met with this guy who works with one of the largest medical device and healthcare companies in the world, and he's the head of epidemiology, which is about understanding population statistics and how it affects people's decisions and how you characterize the health of the community and all that kind of stuff. He's like, I really want to work on a project with you in Austin around health literacy of the community and visualization of that. And I'm like, that's fantastic, don't know how to engage you just yet. And then last week I met an artist here in Austin who's doing really remarkable work, and she's about to do her big reveal, I think, in a couple weeks here in May. But what she's doing is tracking the emotional high, where you have your most extreme emotional experiences in Austin, both positive and negative, and then geolocating them. And it turns out the place where most people have the most positive experiences in Austin is in Barton Springs, right? And then there's some other reason, and there are those places that are just as negative as Barton Springs is positive, and then she's mapping that as a visualization. It's a really beautiful art piece. And that's emotionally a really interesting way to tie your life and your living and who you are as a person to the place that you live.
Not too dissimilar from, there's a topography map of Texas around OSHA reported incidents. Have you guys seen that? It's one of the big graduate students. Yeah.
That probably inversely proportional to the experience.
No, Houston has skyscrapers. But that idea of how do you mash up these what seem to be 3 orthogonal concepts that we interact with every day and actually blend them so that you're marrying information that makes it richer. It's kind of the Gestalt theory, like the sum of the parts isn't just more, it's something different. It's something even potentially better, right? We take too much of an incremental viewpoint as to how we think about when you combine things, like they're each just valuable for the things that they bring. Whereas if you look at them as a whole, it's so much richer than if you just saw them as being summed by the parts.
Right. So the thing we think can come about, and we're going to try to make it happen, is an art installation inside a medical center that invokes and evinces emotion, that is participatory, that draws data from the people who participate with it because they input data. And then you can layer on things like population statistics and geographic and socioeconomic stats and actually learn and characterize places and things that need greater intervention. So it's almost the perfect analogy for why we are between the medical school and the College of Fine Arts, and we're really looking forward to projects like that.
So there's this futurist named William Gibson who says that the future is already here, it's just unevenly distributed. Right? right? And our experience has been that regardless of the industries that we worked in while we're at IDEO, and specifically around healthcare, there are pockets of innovation that create a state-of-the-art experience for people. It's just that not everybody knows about it, not everybody has access to it. Some of the real challenges aren't just with the ideas themselves, or how do you actually make those ideas work together in environments that have different conditions. So we are not Cleveland, we are not San Francisco, we are not New York City. The conditions in Austin pervade a certain environment in which some ideas are possible and others are not, that may be possible elsewhere. When you think about systems, you have to think about what are the conditions that are present so that the ideas that we can imagine are possible can flourish. It's really about understanding what are those ideas that marry with the conditions that we have here, some of which are not new, some of which are, but not in the kind of fancy gadget way, like we're going to put an iPad everywhere and it's going to be cool and new. They're new in how they change the framework of value being exchanged. They're new in the way we rethink the interaction between who's presenting information and who's not. They're new in the way that for where we experience them, not just when we experience them. Those are that's kind of the novelty of what we're seeing a lot of.
Yeah, Beto's response reinforces this notion that our filter is not for whether we create you or we take old and remake it. It's about understanding what the needs are of the system and then finding the most appropriate solution for it, right? And so, a lot of health care traditionally just looks at revising or looking at existing tools and how we can manipulate them, right? And we're not shy about proposing things that no one's ever done before, if it's the most appropriate way to address the issue, right? We're not doing it just to
We love low-tech solutions.
Yeah.
Innovation is not tied to technology necessarily, right? It's about rendering value in ways that is different, right? Innovation is even, the way it's defined, it's not new, it's just different. Yeah, ask Jesse over there. He helped with the FDR research that we did. June, another graduate student, has been helping us think through a number of service touch points. Amazing sculptor, but also kind of has a brain for product design. So our engagement, and it will grow. We've got two fellows starting in the fall. So there are programs where we're bringing in master's students to work with us, and we even in an ad hoc way brought folks from the very beginning to start working with us. Any particular interest in that question other than that?
No, just generally.
Yeah, I mean, we're super excited. That is an amazing way that we can collaborate with the College of Fine Arts.
Yeah, and it's mutually reinforcing, right? We need fresh, creative talent to help us think about things in new ways, and I think people are interested in learning design in its execution, right? And so we have an opportunity to do
And
that.
I'm looking at, Kate, who potentially we can collaborate at some point on some stuff.
And the answer is absolutely. In fact, we might be more oriented towards that vein of thinking than the traditional medical approach. And so, as we've been doing, especially a lot of our design research, one of our goals is actually to bring that materially to the fore. Because I think a system left to its own devices will sort of revert to sort of the mechanisms it always knows, as opposed to challenging the norms. And let's be plain, Austin has a legacy of segregation, right? And the city, to its credit, is trying really hard to overcome that. But the remnants of that history are still evident, right? There is the wrong and right side of the railroad tracks, and it's starting to blend and gray out a little bit. But there definitely is that issue, and the haves and the have-nots. And so there are issues of food deserts and food insecurity and housing insecurity. There's economic empowerment, gender equality, all those sort of things, racial diversity and equality, which have to be addressed. One of the things that the population health department is thinking about in particular is where the variations, where the gaps are, where the biggest disparities are, right? And actually using that as a way to determine where they focus their work first. In particular, and this is remarkable, so CMS, the Center for Medicaid and Medicare Services, right, which is maybe the most uninnovative government entity you could think of, has just declared that it believes that the social determinants of health have an appreciable outcome on your physical health over time. We're like, thank you, facepalm event, right? You're like, okay. But they're putting real money against that. We are collaborating, I'm headed to a meeting just this afternoon, to bring together a regional cohort of organizations to actually submit an application to turn Austin into one of those test beds around testing, screening for social determinants of health, intervening, making screening for the population, making them aware of the resources available, helping them navigate to them, and then actually improving the delivery of those so that we can actually even out those disparities. So it's a critical element. It's often unsaid, and sadly should not be, right? It is one of the biggest issues to improving the health of the community is actually addressing people who have the least resources.
I would think about it also in a kind of generative, from a generative point of view. So when you think about design, you think about being inspired, you often don't want to go talk to the average person. Part of what we're inspired by is that there are opportunities to think generatively by the circumstances that the vulnerable and uninsured population create around how they navigate with health, their interactions with health, that not only would benefit them if you solve for them, but would benefit everybody else. Because their acute awareness of those interactions because of their conditions, it takes them 3-4 bus routes to get to somewhere. It exacerbates the things that we may take for granted that are symptoms or signs that the way we've designed the system is inherently flawed. Those individuals on both ends, the kind of the vulnerable and uninsured and kind of the boutique commercially insured folks who have, whole teams around them, and we see the merit of that, insights into how those things can be improved would benefit all of us. And that's a strategy of design. The strategy of design is not to be quantitative and say, I'm going to interview everybody, and then establish from that a specification sheet that will tell me what to do. Design is about being inspired by the circumstances that you see people go through because of the conditions that they are in. And that's where we get real inspiration for looking at something really different. And so I would, I tend to almost say, like, we are fortunate and privileged to be working with the vulnerable and uninsured population as a means to really transform healthcare.
Here's a really tangible example, and this is not mine, this is stolen from the CEO of the Thinkery. He says, there's all sorts of things that a population, an underserved population experiences that a typical attendee at a museum doesn't. So he'll characterize, most people who come to museums are mothers of white European descent and their children, right?
We live with stereotypes.
And so, what's the first thing you see when you walk in a museum? You see a high counter with the person behind it who's taking your money to give you a ticket. And people who are not of white European descent often have a very visceral response to that because they've been because it's the same notion that a financial institution has when you walk into a bank and a bank teller, right? And that's also the same thing you see in a healthcare setting. Oftentimes they have a glass window, they'll open just a crack so you don't have to breathe the same air that you are, right? And people have a very visceral response to that because a lot of the underserved population has been discriminated against by those institutions historically, right? And so they walk into a museum and they're like, and they can't tell you why, but they have a very visceral response and they're like, I don't feel real comfortable here, and they walk back out. And so the same is true though, so those of us who, of privilege, right, also have an interesting response to that too. Like there is this hierarchy or this high counter, I can't see what you're doing, all that kind of stuff. We have that experience in the airport where the person tells you, no, there are no seats available, and you're like, yeah, right. But and so by working with the underserved and uninsured population, right, some of those things come to the fore, which allows us actually to solve broader problems for the entire population. So it is actually a gift more broadly for us to be working with that population in particular. Not yet, but we have great intention. So the question was, there's a lot of alternative approaches that are not traditional, pharmacological Western-based medicine, right? Ayurvedic and medicine and doulas, and you mentioned, and acupuncture.
And in Germany, like the midwives are in the hospitals.
That's right.
Not here at all.
Well, it's really it's really interesting, right? And so you would ask, why aren't there midwives in the hospital here? I spent a month in Sweden last year doing research on structure and governance of the Swedish healthcare system, which is very fascinatingly different than the U.S. and far more effective, by the way. And the reasons that midwives don't exist in the U.S. is as much political and regulatory and lots of things which are not the right reasons. But the context for care is changing dramatically in the U.S. And so the Center for Medicaid and Med Services, because they run Medicare and Medicaid, they pay for a lot of healthcare in the U.S. And in fact, anything they do, all the commercial insurance companies follow. And what they've done, which is completely remarkable in their history, is they've set a goal by 2018 to shift most of the reimbursement payment for healthcare from I pay you because you did something to I pay you because you actually made a difference. Right? Which sounds ridiculous, but the U.S. healthcare system is, I pay you as a doctor because you did something to somebody, irrespective of whether you made them better or not, which is their poor proxy for care. We're now changing the system so that you only get paid when your patient gets better, right? Which means that the system is now roiled, and they're trying to figure out, how do we deliver better care at lower cost points, which is the question we should have always been pursuing, but we finally got to a structural scenario which encourages that. And so the rise of things like that, like doulas, like midwives, like alternative therapies that actually have effect, are now being facilitated by the change in rules, basically.
So when we said we started off by bringing design to rethink the business model, that's part of it, right? So I'm going to be overly simplistic, but what we're trying to do is allow other providers other than the physician to unlock the reimbursement for payment. Right now, it's bottlenecked at the physician level. They alone can unlock payments. What if, and here's what Stacey was pointing to, what if CMS didn't care how many little things you did, they just cared about an outcome? The responsibility and accountability is now put on the delivery organization to render care. When it's on our plate, we can allow different stakeholders, different actors, different providers to unlock that value.
Yeah, in fact, you might prescribe yoga because that's better than prescribing a pharmaceutical intervention, right?
Or better nutrition through a food diet.
Right.
The interesting thing that's happening here is that we're unlocking who can start the process of getting reimbursed. Formerly, it was these payment models with the physician having to sign off. I'm overly simplistic, but you guys get the gist. That's when the
Subcontractor.
Good. I think we might be short on time. Any other questions, perhaps? Well then, thank you very much.